I'm Linda Bloomfield. I'm a diabetes specialist podiatrist, traditionally working in Westminster, but I've recently been seconded to a team lead role in KMC. And my project is quite a large one, and it is work in progress, but it's entitled Integrated Working with a Partnership Organisation, which is the Imperial College Healthcare Trust, and a review of current community-based diabetes podiatry services. So just a bit of background. Foot complications to diabetes can have quite huge negative impacts on our patients. A few facts for you. 5% of people with diabetes develop a foot ulcer in a year. The estimated annual cost to the NHS of managing foot ulceration in England is £574 million. 500,000 hospital beds in England a year are occupied by people with diabetic foot ulceration, which is the largest of all the diabetic complications, including kind of renal and eye disease. Currently, or no, what used to happen was St Mary's has an agreement with what was then Westminster PCT. That's when I first started working. Since then, St Mary's have become Imperial College Healthcare Trust, merging with Charing Cross and Hammersmith Hospital, and Westminster PCT have become CLCH, merging with the 4 boroughs that we know. The Westminster Diabetes Centre was set up in about 2005-ish, with the idea of having diabetes care in the community, so consultants coming and working with populations closest to home, with specialist nursing, podiatry, retinal screening and dietitians. Recently it's lost its way a little bit. We're not, and I personally work there, so I can say this hand on heart, but we're not meeting NICE guidelines as effectively as we can. Our services are overbooked and stretched. And as much as we'd like to try and put patients at the centre of what we're doing, I don't think we're doing that as effectively as we can. The future of podiatry in CLCH at the moment is quite uncertain. The department is going through transformation, which brings along its own challenges with clinicians being slightly disillusioned and maybe not kind of buying into a process like this. We are under scrutiny with the increased pressure to prove our worth on all different levels, including financially. The CCG is looking at what we're doing, we're having to prove our case with them, and we do have the threat of any qualified providers too to contend with. So we just need to really get our ship in order, really. One of the ways we can do this is through agreed treatment pathways and packages of care, which we hope that can be replicated across CLCH, which can help combat the kind of postcode lottery side of things. And quite a big goal that I have is the formation of improved tertiary level diabetic foot service at St Mary's, which is the hub for the 3 hospitals, which is supported by effective intermediate care podiatry clinics across CLCH. Why I want to do it, or why I think we should do it, QIP and KPIs are a key point of this. So it's a meeting about the NICE guidelines, collecting data from patients and patient engagement with pharma and friends, staff development, staff rotation, patient engagement, with effectively kind of improving the outcomes for our patients. That's the quality part. Working innovatively, doing things differently, working productively and maintaining efficiency. Preventative care, huge in diabetes. We kind of, sometimes we fight this battle at the wrong end when people have their complications already. We kind of need to shift that focus a bit to the beginning. So risk identification, risk stratification and targeting care appropriately for those patients. Seamless care throughout different services for those that need it. As I mentioned, the treatment pathways and packages of care, reducing A&E attendance and length of bed stays, something that podiatry can play a key role in. The productive, so being cost effective, reducing waste, reviewing our timetables and templates, make sure we're using our day fully, which does help us meet some KPIs. So as Leslie says, what I've done so far in this process is I have integrated input from a number of different people. So we do have a diabetes foot specific prompt, which we hope to go through and communications and start using. Communication with two such different and large organisations has proved quite tricky. There are some quite big characters involved. So I have suggested a weekly meeting where we can all get together and review how we're getting on and how we're doing things for the benefit of our patients. We're in the process of transferring patients to more appropriate levels of care. So that is from kind of a hospital setting. Sometimes we kind of keep them even though they're healed and better. Kind of want to hang on to them and make sure they're okay. But what we need to do and what is far more effective is using our community service better. So just kind of stepping down their care. And likewise, in our intermediate clinics, we need to step patients down back into community care too, but making sure that patients are aware of how to maintain access and how to get back in contact with us. As I mentioned, I'm on secondment at the moment at KC, and so I did have to kind of shift this project slightly, but what it has done is give me an opportunity to see the gaps in a similar service, and how if we can achieve it in one borough, we can then translate it to another. I have written management of high-risk foot guidelines, which are on the intranet and are part of the tissue viability paperwork too. And we have, like I said, we have looked at timetables and templates to make sure we are working with them. Next steps, I've got 10 target points. I won't go through them all, but they are all time specific. I'm more than happy to share this with you if you want it. But one of the examples I put up is new clinic template to launch at Imperial sites, aiming to reduce overbooking, maintain productivity, start using PROM, so we can review effectively. We're starting that in January 2014. And my second example is the launch of standardised Rio diaries across the podiatry clinics in CLCH, which we are going to be doing in April 2014. So, to conclude, what I hope I have demonstrated is my adaptability continually with this project in spite of a slight short-term career change. And I hope I've also portrayed the large scale of this project, but also the huge potential benefits it can have for patients and their quality of life, and ultimately the organisation too. To make this review work effectively and to benefit the stakeholders requires methodical working, good communication skills, natural leadership and the ability to set smart objectives, which I hope I can do.
Really good, really interesting. Congratulations as well on this comment, because you are the first empowerment participant to break through the 8A to the 8A series, so well done. When I get funding next year for the programme, and I can say things like that, so well done. The other thing I want to ask, we work with the Hunter Fulham and the Kensington Chelsea Diabetes Services, looking at how do we get more South Asian, African and Caribbean into the service, because they're not overrepresented in using the general diabetes service. Have you done anything around sort of from that outreach and that sort of preventative side that's targeted to those?
Not specifically. I mean, in Westminster we do have an outreach diabetes podiatry service, and it's one of those things that it's on our radar, and we try and tackle it. Like we're just firefighting at the moment, but I think if we can just get it right in one area, and including something like that, it's then much easier to show its usefulness and transfer it to the other boroughs as well. It's like a big mountain.
Because it's really interesting, because Hampstead doesn't really do any outreach, but Kensington does a lot of outreach, and what they say is by doing outreach, they're not being put into the service because they're getting their diabetes update once a year by going on to a session at a certain community group. And also, they don't see that diabetes is actually a disease because all their friends have got it. So it's something that we've been kind of thinking about and battling with and not really seeing whether Does the outreach work? Does it not work? Does it, is there something else?
I think the nature of the beast is that, with diabetes, it only becomes a problem for you when you have a problem, and then it's a bit late then. But hopefully with the packages of care that we're working on, maybe we can develop an outreach package, if you like, that we can demonstrate to the commissioners, this is what we can achieve with this. Because it's just like a menu choice.
We'll catch up.
Have you thought of registering the course in NHS?
Yes. It's happening. Because it's just the problem we have or that exists is great, but it just was too general, and we need to collect very specific data, which is why we have written our own.
So there's a way in which you're trying to mobilise various things within CLCH, but also this is a partnership with Imperial. What's either a success you've had in that partnership, where you feel you've broken through the partnership and you've got Imperial sort of coming on board, or what's your biggest challenge in doing that?
We had very good relations with St Mary's at times. When we started NDT, I was very much involved with that, and there is data that show that when we did that partnership work with St Mary's and Westminster Diabetes Centre, there was demonstrable reduction in amputation rates, which is a huge thing. With personnel changes, that's become quite difficult, and at the moment there are just regular meetings with people for Imperial and people for CLCH. I don't know what's going to make that easier. I think we're just kind of all trying to get to the same goal and making sure that we all appreciate that we're on the same side may help that. But I have, in recent weeks especially, it did get very, very ugly, but I have seen an improvement.
Good.
Thank you.